a treatment algorithm. Like if we diagnose the pulmonary arterial hypertension, after diagnosis, the first step is to assess that patient for the vasoreactive. Why vasoreactive? Because we don't know at which stage this PAH is there. I mean, if the patient is still responding to the medicines, vasoreactive response is present, then the CCB therapy, the calcium channel blocker therapy, is still can be used. But if it is not vasoreactive, non-vasoreactive, then the role of CCB is not there. And then we divide this patient to the low and intermediate or high risk. If it is low intermediate risk, then maybe we start only single therapy. But sometimes in a case of intermediate, we can even choose, depend on the symptomatology, to the combination therapy. But still in lower intermediate, it's okay. But in high risk, we normally start always with the combination therapy. So pulmonary arterial hypertension, non-vasoactive response, and high risk, then we definitely start this patient directly with the combination therapy. And after assessment, 3 to 6 months of a treatment, we see whether the response is there and response is not. If the response is continuous good and the patient still falls in the intermediate or high risk, then we still can choose the triple sequential combination. Depends on the response. And once the patient, the response, and further, like it goes in a lower category, like from the high risk to it is going lower intermediate category, we can further reduce the medication from the triple combination to dual combination. So this is as per the guideline in the newer centers, what we are following, that once we are diagnosing PAH at the expert center, we always go for the vasoreactive response. And once the vasoreactive response is positive, we always need to start the CCB therapy. But if it is the CCB therapy, if the vasoreactive is not there, the patient is not vasoreactive, then as per the stratification, whether the patient is having the low risk category, high risk category, or intermediate category. Now, I'll just briefly tell about some the drugs like a role of monotherapy. Role of monotherapy in a pulmonary arterial hypertension is for the treatment naive patient where the WHO functional class 1 or 2 with the acute vasoreactive responders. And if vasoreactive responders are there, then the patient must be on the CCB, and still the patient does not get better, then the role of monotherapy is there. Long-term historical PH patient with the monotherapy more than 5 years with the no risk or low risk, here the role of monotherapy comes. We should focus the patient should not have any comorbidities and concern for the possible pulmonary occlusive disease. Now, these are the options for the monotherapy that we have. In a calcium channel blocker, we can start maybe the amlodipine or nifedipine. In endothelin receptor antagonist, we have 3 options: the ambrisentan, bosentan, and mesiltan. In phosphodiesterase 5 inhibitor, we have sildenafil, tadalafil, and vardenafil. Tadalafil, the most common drug that used for this PAH therapy. And in prostacyclin, we have the ipoprostenol, ilioprost, and the trazodone. India right now we don't have this the IV prostacyclin, but we do have this endothelin receptor antagonist, phosphodiesterase inhibitor, and in coming time I think we'll probably get this whole formulation, because a lot of work is being going on a pulmonary arterial hypertension. These are different options of this combination therapy. We can use the ambrisentan plus tadalafil if we want a dual therapy for the patient. At the same time, we can use the bosentan sildenafil with the IV ipoprostenol if we want a triple therapy. And this is as per the recommendation like WHO class 2 and class 3. This is just a short thing about this combination therapy in a pulmonary arterial hypertension. This was an Ambition clinical trial. It is a very famous clinical trial as far as the PAH treatment is being concerned. They did study in a 500 patient with the systemic PAH. The primary endpoint with this was a death, hospitalization, and the worsening of PAH. And what they found, that the person who is on a combination therapy responded very well compared to the person where we give the pooled monotherapy. So compared to the monotherapy, the person who received the combination therapy responded very well. And they actually doubling of the 6-minute walk distance with the in the combination therapy compared to the monotherapy. And this response is not like was there at 1 year and after 3 years the response was not there. It is not like this. The response started even after 1 year, and that patient continued to get further better even after 3 years or 5 years. So even at the initial, the combination therapy responded very well, and that response was continued to show even after 3 years. And this is a very encouraging data that we got And as far as like combination therapy, we are worried like whenever we give the combination therapy, the patient may have more side effect. But what we saw that compared to the monotherapy embrysentan, compared to the monotherapy tadalafil, what we found that the peripheral edema, headache, nasal congestion, and anemia definitely were there slight more, but not alarming. Like in case of embrysentan, if the headache are there in 33%, in the combination it is just a 40%. And in tadalafil monotherapy, it is a 35%. So this side effect was not alarming, and the patient could tolerate these all medicines very well. In 2019, the American College of Chest Physician, they told like the naive patient with the PAH who are WHO class 2 or 3, we suggest initial combination therapy with the embrysentan and tadalafil to improve the 6-minute walk test. And for stable and symptomatic patient with the PAH on a background therapy with the embrysentan, we suggest an additional of a tadalafil to improve the 6-minute walk test. So all the guideline before 2015, the working like we should use the monotherapy, not dual because of the side effect, and we are not getting much benefit. Now the things are totally changed. Now they are focusing more towards the combination therapy compared to the monotherapy. As far as the prognosis is being concerned, if the PAH left untreated, it can be progressive, sometimes very fatal. And the prognosis, obviously, of the group 1 PAH is very poor. As far as the survival be concerned, the 1-year survival of the PAH is 85%, and the 7-year survival is just 49%. So this is the prognosis is extremely poor, and these are the further factors that we can relate with the poor prognosis, like more than is more than 50 years, the pressure is very high, the severe PAH, the hypocapnia, some comorbidities like the chronic obstructive pulmonary disease, the diabetes, and the pulmonary associated, the disease that is associated with the connective tissue disease, and patient may be having some, the drug like the SSRI, von Willebrand factor positive, and the episode of the acute PH crisis. These are the factors that is associated with the poor prognosis, and this is what we need to give the follow-up with the PAH, like how frequently we need to do these investigation and how we should follow these PAH patients. So we need to do this medical assessment, everything at the baseline, including the ECG, 6-minute walk test, CPT, echo, and even the basic lab, including the blood gas analysis. And after 3 to 6 months, we need to repeat the ECG with the 6-minute walk test and basic lab also. And at the end of 1 year, we need to repeat all labs. So this ECG, 6-minute walk test, and the basic assessment, we need to repeat every 3 to 6 months since we started the treatment. So what we come to know, what we learned today, that PAH exists. So the most important thing here is because it takes time to understand that is the PAH can cause these much of symptoms, and this is a entity that actually often missed by many even good clinicians. So the PAH normally present with the exertional dyspnea, lethargy, and fatigue. Any person where the exertional dyspnea is there and we are not aware, like we could not find out what is the reason, we should focus on the PH also. Specifically, if we have the echo in our lab and we do the echocardiography and found the high pressure. Though we know that the pulmonary arterial hypertension is diagnosed with the right heart catheterization. It's a diagnostic, it's a gold standard for a diagnosis. But at the same time, we need at least some clue, because if the pressures are 20 or pressures are 50, we can easily, can differentiate whether the patient can attribute the to PAH or not. These symptoms, the exertional dyspnea, lethargy, and fatigue, are frequently attributed incorrectly to age also, because sometimes what happens, the person in around 70s are presenting with the exertional dyspnea. We think that maybe the age is the response, but if still the pressures are high, we should always look for the diagnosis further to look out that if the PAH is exist, and if it is exist, then we need to treat it also once we finalize that the PAH is accepted, but the PAH is actually a pulmonary arterial hypertension. The next new thing that we learned is upfront combination is actually recommended even in intermediate risk. If the PAH is a very low risk, then it's okay to start with a single therapy. Even there, in some cases, the combination can be used, but now at time, the treatment of a choice in a PAH is upfront combination. And IV prostacyclin is only for high risk. But at the same time, we can use the sequential or a combination therapy better than a monotherapy if the response is not there.